Yes? Maybe? Not so much? Okay. My name is Lori Reinhardt, and I'm the co-director of West Seattle Indivisible, and it's my honor to be able to join everybody here today and to help facilitate our panel discussions throughout the day. Because we're running a couple minutes late, we're going to just dive in, right? So first, I would like to introduce our keynote speaker, someone who will have the opening remarks, and that's Chris Roberts, who was elected to the Shoreline City Council in 2009, 2013, 2017, 2021, and 2025. He has served as mayor from 2016 to 2017, and from 2024 and 2025. His current term expires December 31st of 29. Chris graduated from Willamette University in 2000 and earned a PhD from the University of Washington in 2012 in the field of public law. Chris serves as a member of the National League of Cities Boards of Directors and the Puget Sound Regional Council Executive Board. He is the chair of the Sound Cities Association Public Issues Committee, as well as an enrolled member in the Choctaw Nation of Oklahoma. Please welcome Chris Roberts.
A few years ago, my family had the opportunity to walk across the Edmonds-Pettus Bridge in Selma, Alabama. At the time, I was struck by the fact it was children, teenagers, who might have occupied these halls, who led the march. And there were kids as young as 8 who marched on Bloody Sunday, straight into the Dallas County sheriffs they saw at the foot of the bridge. From the bridge in Selma to the commons in Kent State, and now to the streets of Minnesota, the pattern is clear. When power is left unchecked, we pay a price. No one should fear for their own safety in their community, especially from those sworn to protect it. I believe that law enforcement must always act with integrity and professionalism. What is happening in Minnesota this week is the opposite of how our federal government should work. Our government has a duty to care for our general welfare. Our government has a duty to protect our rights. Our government has a responsibility to protect our communities. Instead, this administration is engaged in terrorizing our community. This administration is intent on violating our rights. This administration is killing our neighbors. We cannot afford to sit idly by. We have a duty to act. We have a duty to be brave. We must be brave like Renee Good and Alex Pretty. We must be willing to give the last measure of our devotion to protect what unites us, to protect our Constitution, and to protect our way of life. The march across the bridge did not begin, and nor did it end in Selma. The march for a more just, more equal society is happening in our streets right now. We have a duty, a responsibility to protect our streets, our neighbors, and our freedoms. Sitting with us today and outside are many organizations who are doing the everyday work to protect our community, to protect our rights. What they share in common is a desire for more of our neighbors to assemble, to activate, and to speak up. To speak up to protect our rights, to speak up to protect our neighbors, to speak up to protect our democracy. If an 8-year-old could stand their ground in 1965, what is our excuse in 2026? We are not just crossing a bridge here in Shoreline, in King County. We are building a bridge for the next generation. Our children must feel safe in their communities. Our grandchildren must inherit a society that values human rights. Our great-grandchildren must be able to pursue their American dream, free from tyranny. Let's finish that march. Let's build that bridge together. Before you leave us today, I want you to find one of the organizations here, or at least one of the organizations here. Don't just clap. Don't just sign your name. Don't just agree. Commit your time. Commit your energy. We don't build bridges with words. We build them with our hands. Thank you very much.
Thank you, Chris. That was wonderful. And yes, what he has to say is true. It's not a matter of left and right. It's right or wrong, okay? And that's what we need to think about. Next, I would like to introduce our moderator for this first panel. Maureen Brick Lund is a retired from a portfolio career including real estate, IT, and career counseling. A longtime supporter of universal single-payer health care. She joined other advocates from North Seattle Progressives and healthcare as a human right in 2020, while Washington State Universal Healthcare Work Group was just getting underway. The work group was followed by an ongoing Washington State Universal Healthcare Commission. Maureen, fondly called Mo, co-chairs the subcommittee of the healthcare is a human right and made up of advocates from a variety of organizations who meet regularly to actively track and provide input to the commission as they pursue designing a universal health care. Maureen's going to introduce our distinguished panelists today. And we have a couple of people, ushers, that have index cards and pens. So if you have questions for the panelists, please raise your hand if you've not received a card that you would like to then possibly put your question down. And then the ushers will be collecting them, and we will then present those after each of the panelists have an initial 10-minute presentation. Okay, without further ado, here's Maureen.
Thank you, Laura, for that lovely introduction. So I will get right to the business at hand. Just thinking about Chris's words, and we're building this bridge into the future, and one of the most important components of that bridge has got to be healthcare. And so today it's my honor to introduce our three speakers, Tamara Cunitz, Emily Brice, and Laura Davis. And I'll introduce each of them as they take their turn in presenting their talk to you. And again, if you have questions, please get those to the people in the aisles, and we'll have a Q&A at the end. So to start, we've got Tamara Cunitz, who is a registered nurse and has a master's in master's in community public health. So important. She's the executive director of Nashi Immigration Health Board, which many of you may not have heard of yet, but now you will learn. Tamara received a grant from the state of Washington for Nashi to start that organization, which improves the Ukrainian community's vaccination rate during the time of COVID-19 pandemic. After Russia's full-scale invasion of Ukraine resulted in a surge in the number of Ukrainian immigrants and refugees in our area, Nashi became even busier. The organization manages a warm line of Ukrainian speakers where they can call to get advice on finding health care. It also produces health-related educational videos and printed materials in Ukrainian. Nashi's outreach program actively engages with students in nursing and in public health. So with that, Tamara, I'll give you the podium. Thank you.
Thank you very much, Mo, and thank you for allowing me to be part of this panel. I need to pull up my presentation, but In the meantime, I can introduce myself as I'm doing so. Wonderful. Thank you so much. That was easy. I do a lot of talks, and I am an affiliate teaching professor at University of Washington, so I must say this is a very organized and wonderful event, and technology is working. So I'm Tamara Cunitz, and I'm going to tell you a little bit about how our organization, Nashi Immigrants Health Board, is responding to today's healthcare challenges. Here's some information about me. I know that Mo had introduced me, so I will skip this area, and if you have any questions about my background, I can let you know during the panel. But this is a more important thing that I wanted to share with you. I want to talk about what drives my work, because I am a nurse, and I have been an affiliate nursing professor for many years and a nursing educator, but I always was drawn to work with immigrant and refugee communities because my parents resettled in the United States during World War II after they escaped the communist, Soviet, and Nazi regimes, and they both were Ukrainian citizens who escaped on foot with their families. So I have a very close connection to what their experiences were and how that affected them and all of us, and how that is affecting people today. So in one of the photos this is my mother's side of the family. My grandmother, Angelina Malerchuk, escaped with my mother, and my grandfather was conscripted into the German army against his will, so she escaped alone with her mother and other people in the family. But they did reunite, and there were some amazing stories around that, and they were able to reunite in a displaced persons camp in the late 1940s. 1948 was the year, and that is where my aunt was born. So my grandmother and grandfather had 3 children. One was born in Ukraine, one was born in a displaced persons camp in Germany, and their son, my uncle, was born in the US. So they've had a very interesting lived experience as refugees. My father's side were also, in that same time frame, were escaping the Nazis. And if you have gone to Ellis Island in New York, you can see these trunks that people had to leave with, and they only had one trunk to put their belongings in. This is my family's trunk. They were in a displaced persons camp in Austria, and they filled what they had into this trunk, and this was returned to them later, and we have it in our home as a family heirloom that we can cherish. So those are the things that drive my work, because I know how the struggle is real and that lots of people are experiencing this struggle today. Also, as someone who works in the academic realm, I like to speak about immigration as a social determinant of health, or social driver of health. It is an actual barrier to health. If you immigrate from somewhere else to a new place, you don't have insurance, you have a low socioeconomic status, you mistrust the healthcare system, you fear accessing health, you don't speak the language, you don't have experience with the healthcare system, you have cultural norms that and values that you believe that may be different than the new country you're in, and you have to adjust to Western medicine. So the National Academy of Sciences said that, which is a very quote I agree with, immigration is both a consequence of the social determinants of health and a social determinant of health in its own right. So I also put in some definitions of people who immigrated. They come to live permanently in a foreign country. That is immigration. If they're forced to migrate, they're forcibly induced or moved away from where they are to a new place. And refugees are forced to leave their country to escape war, persecution, natural disasters, or other things that put their life in danger. So our organization was founded during COVID-19 to help our community learn about the disease and how to prevent it. And we were given funding to do some education around COVID-19. Our mission is to partner with our Ukrainian community in Washington, advocating through community engagement, empowering them and connecting them to resources. And our lens is a lens of health, equity, and social justice. Everyone on our team is a community member, and many are people who've arrived within the past 5 years. So we were doing some really great work, and this was around the time frame of the date of the full-scale Russian invasion of Ukraine, which was February 24th, 2022. So this really impacted our organization and the needs of the people who were coming here. So as you well know, there was an international refugee crisis going on, and many of the people coming from Ukraine chose Washington as their state of arrival. And I wanted to share some data around that. We work closely with the Office of Refugee and Immigrant Assistance, and they share the population data with us around arrivals into Washington who've accessed their services. So as of January 2025, since we're not collecting this anymore based on some of the changes, 30,511 Ukrainians registered for services through DSHS and came through a legal pathway called Uniting for Ukraine. And the population of Ukrainians in the statistical data before that time was noted as 64,518. So the increase, there's almost a 50% increase in the population of Ukrainians. This is a very impactful slide because people don't really know that those numbers are so high. And the community here is very active, and this is a very welcoming state, so there's a lot of really great community services and a lot of gratitude from the community. So Nashi is aligned with the University of Washington, and we are able to have scholars be mentored in our agency. And we've done some studies and collected some data on how we can help in these situations. I'm going to move through. We work in mental health, and we work in social services, providing direct services to our community. We do public health education, mental health and peer support, and we do health navigation to help people connect to health services. I will quickly move through this. This is the main point I wanted to bring into this talk, is that on February 24th, not February 2nd, Ukrainians were given legal pathway to the US, and they were given benefits that helped them start to resettle, become engaged in the community, have work authorization, work in jobs, and provide for their families and pay taxes to our state and our country. Over the past year, the restrictions within this realm have been very severe. Since January 27th, 2025, the restrictions on this immigration pathway have been so severe that people are left without knowing what their status is and feeling worried, scared, and unprotected. And this is also affecting our organization. Even though we are able to provide a lot of services, the restrictions on our community are restricting us in serving them because they no longer have those services that we have to make sure they're eligible for. So the cascade is real, and we're really seeing a lot of people having more needs. We have some data about our program. I don't want to get into that, but I wanted to basically end with that our organization, like many others in our community, are really worried about the communities out there who are being restricted from health and social services based on their immigration status and based on the fact that they are working toward becoming community citizens, but now that a lot of that agencies being taken away from them, and they don't have any recourse. So that is what I wanted to end with, because it is a real concern for a lot of our immigrant and refugee communities right now. And I just wanted to give you the story from a real situation within our community. These members who are on our team and who we serve. And I'm happy to answer questions, but I know that I'm out of time, so I would like to end there. Thank you for your attention, and I'll be happy to answer questions later.
Thank you so much, Tamara. An important topic, not just for the Ukrainian community, but what we see around us every day for so many people. I, too, am an immigrant, and so it really I'm a child immigrant, different story, but there's so many of us in this room. I've talked to 3 people already today whose parents came to this country after World War II or during World War II. We're all immigrants. We're in this together. Thank you so much, Tamara. And by the way, I forgot to wear my reading glasses today, so I apologize that I did not mention that you're a professor at the University of Washington, so sorry. And Emily, if I skip anything, please fill in like Tamara did. So our next speaker is Emily Brice. Emily, who's the co-executive director of advocacy at NoHLA, which is the acronym for the Northwest Health Law Associates. Emily has nearly 20 years of experience as a patient-oriented lawyer and health policy strategist, including service in the state government. She's a graduate of the University of Washington and of the University of Chicago. Emily continues at the University of Washington was the law school, and University of Chicago, presumably undergraduate. Emily continues to be a strong advocate for universal health care, both at the state and national levels. Among other things, she co-chairs the Policy and Research Committee for Healthcare as a Human Right, Washington, HCHR, an organization that I belong to as well, and this North Seattle Progressives does. And the whole goal of Healthcare as a Human Right, Washington, is as a coalition of organizations to achieve universal healthcare for all citizens, all residents of the state of Washington and our nation, indeed. Thank you very much, Emily. And we'll turn it over to you.
Thank you. So first, I just want to say I really appreciate the space this today and the chance to be in space with great panelists. I just learned a lot, and I think I'm going to keep learning. And I see a lot of people here in the group that work very closely with us on universal health care and moving the ball forward, including Friends from Healthcare for All, who are in coalition, again, with Healthcare as a Human Right Coalition. So there are lots of opportunities to plug in and get involved in this effort, and really appreciate the chance to be here. My organization, Northwest Health Law Advocates, has been doing this work for over 25 years in Washington. And when I say this work, I mean looking for legal and policy strategies to move us closer to universal health care access for all Washingtonians. And when I say all Washingtonians, I include immigrants and people who live in our state and are part of our communities. Through the course of that work, we've been trying to push closer to a space where everyone has coverage in Washington. We've made a lot of progress in that effort over the years, starting with Cover All Kids effort in the early 2000s. Some of you might remember that effort. And then in the last decade or so, with the Affordable Care Act and then state expansions, have been able to build on that to the point where we got to recently, up to the place where we only had about 5% of our population in the state who were still uninsured, just 5% left. And prior to the current federal administration, it felt like we were just gonna round the corner on that. Like maybe we could close the gap. We were filling in the last gaps around particularly immigrant Washingtonians who still didn't have access, and we could see the finish line in sight. The finish line has grown a little bit further away in the last year or so, with the changes to the federal budget bill, H.R. 1, which some of you may know as the big bad bill or the big beautiful bill, depending on how you think about it. And then the recent expiration of enhanced premium tax credits, those premium tax credits that have been helping people afford coverage on our state exchange, Washington Health Plan Finder. Because of those recent federal cuts, we anticipate that in the next couple of years, 1 in every 20 Washingtonians could have their health coverage put at risk, either directly terminating access for people or making the coverage so unaffordable that they won't be able to reasonably buy it. These are not theoretical cuts. Maybe they've impacted someone that you know or love. Some of the cuts have already started to take effect, and with, for example, the expiration of the enhanced premium tax credits and some cuts that particularly targeted, unfortunately, lawfully present immigrants who are very low income, we've already seen tens of thousands of Washingtonians lose coverage just this month. That was just reported in the Seattle Times this week. And that's just going to keep going over the next couple of years. So we've got another big wave of folks who are slated to lose coverage in October, as we were just hearing about. We have more coming after that with the imposition of Medicaid work requirements, which, of course, most people who are on Medicaid, which is called Apple Health in our state, are already working. So it's just, red tape and bureaucracy that's designed to trip people up. And we anticipate that about 400,000 people in Washington will ultimately be impacted. I don't know about all of you, but for the first time in a long time, I'm starting to have conversations with my friends and family about, maybe I'm not going to get insurance after all. And that's a real setback based on where we've been. Okay, so what if you're lucky enough to keep your coverage? And I'm going to talk about the bad stuff first, and then we're going to move on to what we can do together, because this isn't all going to be doom and gloom. So let's say, for people who are going to retain their coverage, right? For those of us who are lucky enough, there's still a lot of really critical issues that are escalating in this environment. So. First one I want to highlight is around privacy and safety, particularly for immigrant communities and communities who have sensitive reproductive or gender-affirming care needs. There's a lot going on in this area, but I'll highlight one piece, which is that earlier this year, ICE and the Department of Homeland Security stole data from the Federal Health Agency, Centers for Medicare and Medicaid Services, for 2 million Washingtonians. Thank you. And has continued to steal this personal private information for 2 million people who try to get access to health care in our state. And we were able, with the Attorney General's office help, to stop that for a period of time, but they have just started to resume it again. So we have this very acute problem where people are trying to get health coverage through this state and federal program, and their privacy and security are placed at risk because of it. So that's a big concern right now. Another big concern is around affordability, and I think all of us feel this in our everyday life. But we just did, my organization, and worked with others to just do a survey of affordability of Washingtonians, and what we found, it's really sad. We saw that 2 in 3 Washingtonians that we surveyed did not access care that they needed in the last year alone, just due to cost. And, that makes sense because premiums have doubled over the last decade. And we're seeing that this issue is impacting people at the lowest incomes and also even people with higher incomes, right? All of us are struggling with affordability right now, regardless of where you get your insurance from. And we saw that 1 in 5 of the Washingtonians that we talked to had outstanding medical bills. So really kind of acute affordability and access problem there. And then the last piece that I'll mention around kind of challenges we're facing that are being compounded and exacerbated by the federal situation is we have existing access challenges in the state, right? All of us who've had to wait for primary care, behavioral health, we feel that acutely. And that is being worsened by the introduction of consolidation, of private equity, of this increasingly corporate healthcare environment. I don't know about all of you, but as I was driving over to come here this morning, I noticed there was a Trader Joe's and then there was an Optum healthcare clinic. And Optum, as many of you know, has control over 10% of the physicians in our nation, right? So these are the kind of forces that are prepared to kind of sweep in at this moment where our healthcare system is uniquely vulnerable, patients are really struggling, and try to turn a quick buck. Okay, so I know my time is running out, and I've just said sad things so far. So let me give a little bit of a hopeful take about what we can do moving forward. I'm sure we'll hear from Rep. Davis about some of the challenges that we're facing this legislative session. We have a very significant and ongoing multi-billion-dollar revenue shortfall, and we are in a short 60-day session. It's hard to do a lot. What I see as our biggest risk is paralysis or fear, because there are so many different changes happening all at once that I see policymakers are really having a hard time balancing it all and figuring out like how to make good policy in this time. But I'm hopeful that we can kind of rise above that inaction and just get started at chipping away at some of this. What we have to do in order to make any progress and even maintain the coverage and the healthcare that we have right now is to raise progressive revenue. We are going to need additional funding. The governor's budget that was just proposed gives us a picture of what it looks like to not raise a significant amount of revenue this session, and it is at best maintaining the status quo, and at worst significant cuts. So, for example, one of the programs that we worked on to improve access to coverage for immigrant Washingtonians took a $60 million hit in the governor's proposed budget. So we're going to have to dip into the wealthiest Washingtonians and wealthiest corporations and see what we can do there. There are a lot of proposals on the table, and we were happy to talk a little bit more about some of those, but Washington is a wealthy state. We should not be a state where we're seeing hundreds of thousands of Washingtonians go without basic health care. And a lot of the energy this session will be going towards maintaining the funding that we need to be able to do our best to chip away at some of these federal pieces. So protecting the Apple Health program, protecting our state Cascade Care Savings program, which is a state program for premium assistance, maintaining as much care as we can for people who are losing coverage, and we might not get all the way towards full coverage for everyone, and I'm out of time, so. But just starting to try. And then I think putting a couple of common sense guardrails on the corporate behavior that we're seeing right now. So for example, Senator Robinson has a corporate practice of medicine bill that we could talk about. Rep. Taylor and Senator Dingra have a kind of oversight bill around private equity. And so just trying to hold the line about some of those corporate factors that we were talking about earlier. I could say more, but I will maybe leave it there and then come back. And I think hopefully in the questions and answers we can get a little bit into some of the movement and excitement around universal health care strategies as well, because what I talked about was a little bit of a right now framework, but we need to be pushing past that as well.
Thank you, Emily. It's such a big job, but now you get the good news and the bad news. Bad news being the situation we're in, the good news being that we can make a change. And we know what a lot of extra money would sure help, so there's money out there somewhere. So my next speaker that I'd like to introduce is Representative Lauren Davis from the Legislative District 32, which many of you might be in Lauren's district. We are in Lauren's district right at the moment. And this is a very large district. It goes from Linwood to North Seattle, Woodway to Montlake Terrace, and includes all of Shoreline. So besides her work as a legislator, Lauren is the founding executive director of the current strategy director of the Washington Recovery Alliance, which advances mental health and substance use recovery by changing public understanding and shaping pro-recovery public policy. Lauren has led efforts that resulted in the passage of Ricky's Law, which created an unprecedented crisis treatment system for youth and adults with life-threatening addiction. Her work in the legislature continues to center on behavioral health treatment and recovery, as well as the criminal legal system reform. Thank you very much for being here, Lauren. I'll turn it over to you.
Thank you so much. Good morning, everyone. It's so wonderful to be in community with all of you this morning. I want to just echo the thanks to the organizers. This is really, really incredible to put this on, all volunteer effort. And thank you to all of you. It is Saturday morning and you could be anywhere and doing anything, and yet here you are standing with your neighbors and standing up for your neighbors. I will certainly focus mostly on behavioral health policy, which is what I was asked to talk about this morning, but I would be remiss not to mention just how incredibly heartsick I am about what's happening in our country. And I want to let you know that in the legislature, we are doing absolutely everything that we can to stand up to this administration, to stand up for our immigrant neighbors, our refugee neighbors, and we will be coloring all the way up to the line of what is allowable under a state law and federal law for us to do everything that we can in that regard. It's also just been, given what's going on, deeply moving to see everybody here and to see all the organizations outside, to see flyers talking about standing up for our neighbors and resisting ICE. So thank you for that this morning. So my colleague Emily talked about, at a high level, some of the impacts to healthcare. I want to mention just a couple things specifically, and things on sort of the hopeful side, what the state may be able to do. So out of 8 million people in this state, approximately 2 million, about a quarter of us, receive our health insurance through Medicaid, through Apple Health. And Emily talked about we're looking at projections somewhere up to potentially 400,000 of those folks losing coverage, largely not due to categorical exclusions, but actually due to administrative paperwork burden. So I had an opportunity this interim to attend a conference of national leaders in New Orleans talking about what we can do, and there's a lot of interest and energy in things like looking at automation for renewals, I've got some ideas around things like creating something like a TurboTax for insurance renewal that is multilingual, and how can we make it as low barrier as possible for folks? How can we make sure that we're simple things like reminders in the context of the court system, we were actually able to significantly reduce people's failure to appear in court on criminal cases simply by implementing text reminder systems. So can we do something like that for health insurance? In my line of work in substance use disorders, there's a therapeutic modality called contingency management, which basically essentially has to do with rewarding people for certain behaviors, and in that context primarily having to do with maintaining recovery goals. But can we use some of those same learnings? Can we provide, can the state potentially assist with things like, gift cards, things like that, if you get your insurance renewed, right? Because obviously there's a lot more savings to that family, and then also to the state if we make sure that they maintain their coverage. There's also ways that all of us can help. So there are certain exemptions about who's required to get to follow these work requirements, but there's also volunteer hours that can count as a substitute for work requirements, and so there are ways that many of the organizations represented here can help provide volunteer opportunities and ways to sort of meet those hours and check those boxes. One of the pieces that stands out to me the most I mentioned that for the most part, the exclusions come in the loss of coverage comes primarily in the form of administrative burden, but there are certain groups, of course, that the administration is targeting, immigrants and refugees being chief among them. One statistic that I wanted to mention, I had a meeting this week with SEIU 775, which is our caregivers union, and there is a population of 3,000 Washingtonians that are in our long-term care system right now. These are among our most vulnerable residents, and they will be losing their coverage entirely. And what I find so painfully ironic about that is the majority of our workforce in the long-term care system are immigrants and refugees. My own grandmother, who I took care of at the end of her life, was in an adult family home, and She was cared for entirely by immigrants from East Africa who treated her as if she were their own grandmother and gave her an extra year of life because of the work of their hands and the care and compassion they provided. So unfortunately, the governor's budget only provides funding for 500 of those 3,000. So I am deeply committed to trying to make sure that that population specifically is not losing coverage. So to pivot to behavioral health specifically, we have made a lot of strides in the state, but unfortunately, some of that progress is potentially under attack because of the state's budget situation, actually, and because of what's happening at the federal level. So some of the things that we're really proud of in 2021, we were among the first states to pass a statewide implementation of 988, the behavioral health emergency line, and we passed on a, believe it or not, on a bipartisan vote in the State House, we passed a telecom tax, so a tax on cell phone lines to cover the hubs that receive these 988 calls, and we're seeing a huge increase in demand. That demand has increased even more because the federal government eliminated funding for the LGBT specialty crisis line, and so those calls are now being received by 988. We've been working really hard to implement what we call the Crisis Now model, which is somewhere to call, which is 988, someone to respond, which is a mobile crisis team, or in some cases a co-responder team, and then somewhere to go, which are these crisis receiving facilities. So think like a behavioral health emergency department, open 24/7, treats everybody, insurance blind, specializing in care for people experiencing mental health, substance use challenges, or suicidality. We have just one of those in the state right now, which is in Kirkland, operated by Connections. I'm very proud, perhaps my proudest achievement as a lawmaker is providing, sort of spearheading the creation of and getting the capital budget funding for Linwood's Crisis Care Center, which is set to open Q1 of this year and will certainly be open to everybody, but primarily, presumably, serving residents from North King County and southwest Snohomish County, which will be operated by CMAR, which is, of course, an agency that's got a lot of specialty in serving our immigrant and refugee communities in particular. In the substance use disorder world, which is largely where I have spent my career, prior to my arrival in the legislature, the focus of the state's response to substance use disorder had primarily been treatment. And treatment is, to be clear, incredibly important. And treatment means many, many different things. But when we think about the substance use disorder continuum of care, there's really three legs of the stool. There's what occurs prior to treatment, so that's what we would consider outreach. So we have to actually get to know a person, be in a relationship with a person, and help them find that little glimmer of hope and that little window of willingness to even be willing to engage in treatment in the first place. So that's what we would call outreach, and then you have treatment, and then you have what we call recovery support services, which is all of the aftercare, everything that keeps that disease in remission. Addiction is not dissimilar to cancer. It is a chronic progressive disease that can be fatal, and it can be placed into remission, but there is no cure. So we really need to make sure that we're providing that ongoing care. To not provide the recovery support services after a person may complete, let's say, an inpatient treatment would be akin to having a person receive surgery and then not funding any of the physical therapy after the fact and then blaming the surgery as a failure. We have to provide things like recovery housing. We have to provide things like peer support. We have to provide pathways to education and employment, particularly given the significant overlap between persons experiencing substance use disorder who have had prior involvement with the criminal legal system. But unfortunately, insurance does not cover two legs of that three-legged stool, and there's no insurance coverage for all that outreach work for the most part, and there's no insurance coverage for recovery support services. We only cover treatment. And so I have worked really hard. This is my 8th legislative session, and I've been fiercely dedicated to providing significant funding for the other two legs. And we were able to, in 2021, expand outreach services statewide in the form of the Recovery Navigator program, which was a statewide expansion of the LEAD model. It's the only behavioral health program in every county now. But that program is under attack because of funding cuts, because it's funded by the State General Fund. We've also had significant investments in recovery housing. We have now over 600 recovery residences, including many in our legislative district, that support people in early recovery from addiction, and that is also facing potential budget cuts given the current budget climate, which is why I'm so fiercely committed to making sure that we seize this moment in human history and political history to make significant strides with progressive revenue so that we can make sure at a minimum we stop these very painful cuts, but that we create a pathway and an avenue such that in the not so distant future we're able to actually provide advances and enhancements and more services for behavioral health and healthcare more broadly. So thank you all so much and look forward to your questions.
Thank you so much, Lauren. It's so great to hear such a clear voice and to lay out the situation and the problem that as it is. And I can't help but thinking that eliminating support for the outreach and the support after treatment leaves only treatment, which is the place where healthcare makes its profits. And so, I mean, this is my own personal opinion. I wasn't asked to give it, but that is the problem with our healthcare system. So my childhood was in Norway, where I think you famously know they managed to care for people without putting such an emphasis on profits. So this is a wonderful mirror that you've held up to us today. I thank you so much. Now it's my job to present questions from the audience. We have quite a few questions here. So this is a really big question, but I'm going to throw it out there because I want to respect the audience questions that came up. What is the biggest hurdle in passing universal health care in Washington, and what can be done to overcome that hurdle? And I'm looking at Emily because, of course, that's her bailiwick. So would you like to address that, Emily?
Political will. And let me break that down a little bit. And also, we have a lot of great people here, so I'd love to have a conversation about this. I think all of us know what needs to happen in healthcare, right? To Mo's good point about what we see in other states. And somehow there is a fear that keeps us from getting over the hurdle. And I think a big piece of that is fear of the unknown, right? Nobody wants to be the policymaker who is in charge of a big systems change. And then, of course, folks with current insurance through employer-sponsored insurance, union insurance, right? Who've gotten to the point. Those of us who've gotten to the point where we are lucky enough to have a little bit of something. It's very hard to feel like, oh gosh, what if that changes? What if that's taken away, right? What is exciting about this moment and where I see some opportunity for movement is, first of all, the H.R. 1 cuts, these federal cuts that we just talked about, kind of reshipped the balance, right? All of a sudden, it's not like, oh gosh, almost everybody has coverage through this current system. No, we're facing a significant setback here, and we have a couple of different ways to respond to that. We can either try to claw our way back up in the current system, which will take us decades, or we can really think about something different. And so I think it's kind of jostling people's sense of what might be possible, and that's really exciting. And I also see a lot of really good work happening in the legislature. Lots of bills introduced this session, people kind of interested in pushing the envelope and starting that conversation in a different way. And then really importantly in the Universal Health Care Commission, and I know we've got a lot of folks here who are very involved in that. The Universal Health Care Commission is a state body that it was set up several years ago that is charged with moving us towards a universal single-payer healthcare system, and has done good work to explore the technical issues that need to be explored in order to have a transition, and is with the help of a lot of advocates moving that momentum forward. Now, critics of the Universal Healthcare Commission may say they're not moving fast enough, and I think certainly that's something that we're all feeling right now. But they are, I think, step by step trying to put that roadmap in place. And so the work for us as activists, as supporters of that, is to push them and then try to provide support for the recommendations that they can move towards. So those are a couple of reflections, but would welcome additional thoughts.
Excellent. Now, I want to remind everybody that there's lots of tabling going on out there, and many healthcare or groups that can give you more information, and we're in community, so to join with the other people involved in these efforts is great. So from a really broad question to a smaller question for Tamara, what can a family doctor do to assist in your efforts? My daughter, I'm reading from the card, my daughter is a family doctor who works at Swedish Hospital.
Thank you for the question, and thank you for presenting a question that you would like to support people. The things that I can recommend based on being the director of a health board is connect with those community health boards in your community of patients. For example, Ukrainian communities have us as the Nashi Immigrants Health Board. Their Somali community has a strong health board, the Somali Health Board. All of those people are professionals, they have healthcare background, and they are advocating for their community to get better connection to services. So that is one recommendation. Looking at those community-based organizations who have the lived experience and are able to connect you to the information. The other thing for health practitioners is a culturally and linguistically responsive care. So having translated materials or making sure 100% that interpreter services are available and it's not stigmatized. It takes longer, but the quality of care improves, and then the cost is decreased if your patient gets a good appointment and doesn't have to come back or misses something and has to go get emergency care. So those things are things I would recommend to health professionals to create those areas for people to be able to connect with the healthcare system.
Thank you, Tamara. And that you brought up the Somali Health Board, and I've had some interaction with Somali Health Board, wonderful people, and providing such great service. And there are many, because I did not know anything about Nashi serving the Ukrainian community until today, or preparing for today. And we noticed that there are lots of different segments of society that have health boards that can be useful. So practitioners should connect with those to get information as is recommended. So now we have a question that might be perfect for you, Lauren, is how can we help people who have the most need find and afford mental health care?
That's a terrific question. Thank you. So fortunately, as I mentioned, we're working on the rollout of these crisis care centers, and while there's only one currently, and as I mentioned, another coming online, and a third will be open in Capitol Hill, the state has been really dedicated to funding capital budget investments for those around the state. And those facilities operate akin to an emergency department, so they are insurance blind, and they will treat all persons who present for care. So we do expect, actually, given everybody having their healthcare coverage cut through various means and mechanisms, that we will see an increase in need. So making sure that the state is providing ample provision for the operating of those facilities. Fortunately, in the Affordable Care Act of 2012, there are the 10 essential health benefits, and mental health care and substance use disorder care is among them. So health plans are required to provide that. My freshman year in the legislature, I had a bill that seemed somewhat insignificant at the time, and it codified basically the entirety of the Affordable Care Act into state law should anything ever happen to that federally. And it meant nothing at the time and now means a whole heck of a lot. So those provisions are also enshrined in Washington state law as well. But we do need to make sure, while people who have insurance have access to behavioral health coverage, that we continue to provide access for those who don't. There's other funding mechanisms that provide access to behavioral health for individuals who are uninsured. So this district straddles King and Snohomish counties, and both counties have a 0.1% behavioral health sales tax, and that provides funding for folks who are uninsured or underinsured to access behavioral health. None of it is adequate, but it's a significant priority of mine to make sure that that access is continued.
Thank you. Thank you. And I see Dave's hand. I keep meaning to ask, well, how are we on time? Because we're done. Well, all right. At least we got a question for each of you. I'm so glad. And I want to thank the panelists so much. There's some really great questions here. And we can, if you have them in your head, you can have them answered at the tables or with these various organizations that are represented here, our state government, the University of Washington, and Northwest Health Law Associates, and Healthcare as a Human Right. So thank you very much. And thank you for keeping time, Dave. And to our panelists, I thank you so much for coming today. Thank you.
That was terrific. I hope you learned a lot. I know that I did. And thanks again, everyone, for spending some time with us today. I know that you have very busy lives, and we appreciate it very much. So thank you so much, Lauren, Emily, and Tamara. Thank you.